In this module, we're going to discuss some of the issues regarding long-term effects of cannabis, some of which are still quite controversial. It's important to note that long-term effects studies have been done in the context of recreational cannabis. And of course, generally speaking, such cannabis is higher in THC than medicinal cannabis. High THC street cannabis varieties are generally, probably inaccurately, called skunk. The average proportion of THC in cannabis on the street has steadily increased from around 10% 10 years ago to around high teens or even 20% these days, and there are some varieties as high as 30% THC. And of course, street cannabis can also include unknown products, which may have confused some of the studies on those long-term effects. So with that caveat, let's have a look at some of the problems. And the main one is psychosis, particularly in the context of schizophrenia. The big question is, does cannabis trigger psychosis? The answer is almost certainly yes. But we have to remember that it's still down to the product high in THC, while CBD is known to be antipsychotic and therefore has the opposite effect. And we know in particular that THC can induce transient symptoms similar to the positive cognitive effects of schizophrenia, even in healthy individuals. However, those problems are generally short-lived and will not themselves constitute a psychiatric illness. It's also clear from the literature that THC can exacerbate symptoms in people already suffering from psychosis. And indeed, the use of herbal cannabis can tend to reduce the age of onset of psychosis, particularly, of course, if it started early in adolescence. The prognosis for psychosis is worse in those who have used cannabis for longer in patient studies and have had more readmissions. It also seems likely that people with a genetic predisposition to developing psychosis, such as a family history of schizophrenia, they're more likely to develop psychotic symptoms following cannabis use. However, the link between cannabis and psychosis is by no means firmly established, and we do have to place this into context. It's a very interesting study by Hickman and colleagues in 2009 that considered how many cannabis users would need to stop that habit in order to prevent just one case of psychosis. The estimate was surprisingly high. For men aged 20 to 24, 2,800 heavy cannabis users and more than 10,000 light cannabis users. And for women of the same age, the figures were even more dramatic in that 7,700 heavy female cannabis users and 29,000 light cannabis users would have to stop the habit to prevent just one case of psychosis. It's unlikely, in fairness, that any one factor, such as cannabis use, can cause schizophrenia on its own. Cannabis may well be just one component cause of the development of some of the symptoms of schizophrenia, whilst the illness, of course, may develop from many other genetic and environmental causes. We should remember that most people who use cannabis do not have schizophrenia, and most people with schizophrenia have never used cannabis. Based on the evidence we have currently, previous history of schizophrenia or psychotic episode or a family history of schizophrenia should probably be a contraindication to the use and prescription of cannabis. What about dependence? The generally accepted figure for dependency on cannabis is around 9%. This compares to a dependence rate for alcohol of around 15%, cocaine around 17%, heroin around 23%, and tobacco around 32%. So the risk of cannabis dependency is relatively small, but nevertheless, of course, it's some concern for that minority population. Again, it's worth reminding you that it's cannabis that is particularly high in THC that will tend to cause dependency, and most dependency is seen in recreational users rather than medical users. We also know that it's more of a problem in adolescence and early adulthood. Those starting cannabis at a younger age basically have a higher risk of dependency. So it's an issue mainly, again, for the recreational population. A diagnosis of dependency, as defined in ICD-10, is a cluster of physiological, behavioural and cognitive phenomena in which the use of a substance takes on a much higher priority for a given individual than other behaviours that once had greater value. The central characteristic is a strong desire, a sense of compulsion to take the substance, and difficulties controlling the substance-taking behaviour, as well as the physiological withdrawal state when you stop the drug. So cannabis use disorder, as it's called, is certainly an issue, and it needs to be taken seriously. Referral may need to be made to addiction or substance misuse services. Prior dependency is certainly a relative contraindication to using cannabis as a medicine. So an issue, certainly, but not a huge issue. What about cognition? Again, it's the THC component that seems to cause cognitive problems in the longer term, while CBD does not. We know for certain that THC can impair psychomotor performance and cognition in the short term. There's much controversy about the potential cognitive damage for longer term usage. Most studies have shown that the residual effects on cognition pass after a few hours, or at most a few days. And many studies have shown no longer term effects at all. Some studies, though, have confirmed documented deficits in cognition, such as problems with attention or concentration or working memory, in the longer term, but other studies have refuted that suggestion. Some have shown that if cannabis is started at a younger age, in adolescence when relevant parts of the brain are still developing, then there is a slightly higher risk of long-term cognitive problems. But again, there's certainly a close related effect, and heavy recreational users have more cognitive deficits than longer-term and lighter users in those studies that have shown any long-term effects. At the moment, it's fair to say there is no firm evidence that suggests that cognitive problems of cannabis use are sufficiently severe to cause concerns for the general medical user. But again, it may be sensible to suggest that prescription in adolescents needs to be given with care and thought, given the probable susceptibility of the developing brain. In making advice on the prescription, obviously one has to take into account the potential effects of other drugs that may be used or could be used for that condition. A prime example is childhood drug-resistant epilepsies, where children have often been on 6 or 7 or 8 different anticonvulsants, all with a whole range of side effects, including cognitive and behavioural difficulties. Thus, using cannabis as an anticonvulsant may actually be more beneficial in terms of improved side effects, let alone for better seizure rate, than continuing existing anticonvulsants, let alone adding another one. This particular case in epilepsy, and CBD should be used as the first choice, and dominant strain, with only modest amounts of THC added in if necessary. This should avoid any long-term cognitive problems in the developing child's brain, although we certainly need more studies to confirm or refute this proposal. There's been some work that has shown that long-term cannabis use gives rise to reduced brain volume, particularly around the hippocampus and the amygdala. However, in fairness, other studies have shown no such change. In one overview, authors looked at 13 reasonable quality studies of brain imaging in cannabis use, and found 6 of those studies reported such reduced brain volume, whereas the other studies did not do so. If there's any reduction in brain volume, it's mainly due to the high THC component and relatively heavy recreational use. It's also worth pointing out that even if there is some reduction in brain volume, there is at the moment no indication that has any detrimental long-term effect, and the relevance of the reduced brain volume is simply unknown. Let's now examine cannabis and lung cancer. Now, it's important to emphasise from a medical perspective that smoking cannabis is not recommended. There's controversial evidence about smoking cannabis causing lung cancer. It is theoretically possible, of course, that cannabis does contain some of the carcinogens found in tobacco. And of course, we also know that many recreational cannabis smokers also smoke tobacco, thus confusing any epidemiological study. Some studies have shown no connection between cannabis smoking and lung cancer, and other studies have shown such a link. However, we also know that THC can inhibit a proportion of the enzymes necessary to activate some of the carcinogens found in the smoke, and thus it may actually provide a little protection. There are safer ways of taking cannabis, such as vaping or oils or even the edibles, rather than smoking. Another point about respiration is that heavy recreational cannabis use can lead to bronchial damage in those who are vulnerable, such as those who are immunosuppressed. They can lead to recurrent chest infections, but again, there's a problem with smoking and should not occur with the other methods of ingestion. A couple of other points to mention about long-term problems. First is an unusual condition called cannabis hyperemesis syndrome. This is characterized by cyclical periods of vomiting and often stomach pain, lasting for several days and in a few people, several months. Usually, fortunately, it's self-limiting. It tends to occur in regular heavy cannabis recreational use, and so we can't absolutely be certain that the cause is purely cannabis related. It's very rare in the context of medicinal cannabis use. It can be very severe, and hospital admission is even required, particularly for rehydration. Usually, though, it stops once the cannabis usage stops. And pretty oddly, it can be improved by taking a hot bath or a shower, for reasons totally unknown. The cardiovascular effects are worth mentioning for cannabis use, in that it is a known common complication of high THC cannabis strains that leads to a rapid heart rate, which is usually just uncomfortable and usually of no consequence, though it is a relative contraindication in those with various forms of cardiac disease or cardiac arrhythmias. A few studies have shown an increased risk of heart attack after cannabis use, but that is by no means certain and in any case is a very rare complication. There have also been a few reports of stroke, again usually in heavy recreational users. But we really do not know if there's a chance association or whether there is in a small number of people a predisposition to stroke after cannabis use. Just to illustrate the problems, a study from Colorado compared those who had a heart attack who tested positive for cannabis compared to those who suffered a heart attack who did not test positive for cannabis. And they found that the cannabis patients were actually less likely to die than those who were not using cannabis. Thus, the situation with regards to cardiovascular effects is very unclear. But again, it may be wise for doctors to be cautious in recommending or prescribing cannabis, particularly the high THC varieties, for those with serious risk factors for stroke or heart attack. What about allergy to cannabis? Does that occur? But it's usually extremely rare, and in fact it's more likely for people to be allergic to some of the components of the cannabis delivery system, such as an allergy to alcohol, if that's been that process used in that extraction. Itchy eyes, worsening of asthma, facial swelling or rashes have been described, but mainly in those who smoke or vape cannabis. There's also sometimes a cross-reactivity in people who have some food allergies, such as particularly an allergy to peach, banana, apple, nuts and tomatoes, sometimes called the cannabis fruit-vegetable syndrome. Again, these are very rare reasons to avoid prescription of cannabis. What about pregnancy and breastfeeding? It's best to avoid, of course, any drug during pregnancy. There's been no definitive studies on the effect of growing fetus on cannabis usage. Some studies have shown fetal abnormalities in those mothers who have been using cannabis during pregnancy, but there's certainly no clear-cut cannabis fetal syndrome. Also, during breastfeeding, it's known that cannabinoids can pass into the breast milk to the baby. There's been no definitive studies of harm caused by this transfer. However, like any drug, cannabis is certainly best avoided in pregnancy or during breastfeeding, if at all possible. So that summarises, I hope, some of the long-term problems of cannabis usage. It may be best, as we've said, to avoid prescription, particularly in adolescents, of those who are predisposed to psychosis or schizophrenia. And as always, there should be caution in prescribing in adolescents because of the potential problems with the developing brain. But generally speaking, cannabis has been used for a long time, and we know that in the great majority of people, particularly the low THC varieties, it's a remarkably safe drug. Thank you.